Okay, so plan. Again, like we learned in med school, this should actually be assessment and plan, but in Cerner it's just plan. So you're going to have to insert your assessment. Always use free text for this section. And I already have one pre-made. So your assessment, again, it should be a cohesive piece of thoughtful information from a physician, and in particular for another anesthesiologist, because eventually you're going to look back at other people's notes and you're going to want to see something like this. So just read through it. In Baby Miller, Morgan and McHale, or any of our textbooks, they have a nice outline of what you should include in your anesthesia plan, and it usually includes something about pre-op management, like do they need oral Versed before they go back because they're really anxious? Do they need aspirin because they have a bare metal stent and they forgot to take it this morning? Intraoperative concerns, like is their airway exam really horrible and you need to mention this and get ready for a possible awake fiber optic? What kind of airway, if any? Possible sedation? Do you need any other monitors other than standard? Is there going to be some crazy positioning, like prone, or I guess that's the craziest thing we do, lateral. And then something about IV fluid management, if it's an issue. And then mention post-op pain control plans and ventilation. So here's an example with our patient. Mr. Smith is a 72-year-old male with hypertension, diabetes, hyperlipidemia, COPD, and colon cancer who presents today for laparoscopic right hemicolectomy. He is compliant with his blood pressure medicines and has held his lisinopril for 24 hours and took his metoprolol this morning. His diabetes is well controlled with diet and metformin. Last dose was 2 days ago, and his blood sugar today is 125. He took his statin this morning. Though he has several risk factors for coronary artery disease, age greater than 45, smoker, hypertension, he denies angina, neck pain, arm pain, and stress test from outside hospital is negative. But I will have Esmolol drawn up for induction and emergence. His COPD is his limiting factor. He is not on HOMO 2, but he can only walk slowly up one flight of stairs on some days. He takes Combivent 4 times per day. Given his lung disease, it will be important to limit IV fluids, but his hypertension has likely yielded him intravascularly depleted, so I'll use colloid more than crystalloid. His airway exam is reassuring, and he is edentulous. So this is basically what you would say to your attending when you're giving them your summary. It's just putting it down on paper, and actually for me it's been a lot easier to present a case or staff a case when I've already written it out like this. And then this should help you with oral exams as well. So that's your assessment and then your plan. So for this patient, I would give albuterol nebulizer in the pre-op area. I plan for a standard induction. I plan for just 2 peripheral IVs. I want an art line for his diabetes, and then possible large fluid shifts, especially in case they have to open. I would avoid nitrous given laparoscopic bowel surgery and also potential for aortic embolus, which could be devastating because this patient might have a component of pulmonary hypertension given his horrible COPD. And post-op pain control will be achieved with IV Tylenol, Dilaudid, and single-shot TAP blocks. So I've addressed my concerns intraoperatively, post-operatively, and then also just going to state concerned in the PACU will be pulmonary toilet. Monitor ABGs as necessary, and I'm going to limit opiate use. And then I always like to put this in: we look forward to participating in the care of Mr. Smith. Anesthesiologists are consultants, and this sort of, I guess, reminds people of that. And that's it. There's your note. Look at it in the published view, and be happy. Okay.